critical care management in the ICU. So I started off with my patient information. The patient that I decided to do my case study over was 81 years old. He was 71 inches tall, or 5'11", and he was 75.3 kilograms, which also is about 165.5 pounds. This patient was admitted on July 7th of 2020, and the code status on the chart was DNR, but okay to intubate. I asked a little bit about this because I had never seen this type of code status before. And what I was told, which I found very interesting, was that this patient didn't want compressions, but if their respiratory system started to fail, it would be okay to put that ET tube in. So just no compressions due to the age, but the ET tube would be acceptable for them. Excuse me. So the chief complaint was the heightened shortness of breath or dyspnea, as well as a fever. And so that admitting diagnosis that was determined was septic shock and left lower lobe pneumonia. So the reason that this patient came in was that it was 2 o'clock, July 7th, middle of the afternoon, and this patient was having a hard time breathing. They just felt like they couldn't catch their breath. They had some pressure, but denied any pain in the chest. There was a fever that had been present, so this patient's wife called EMS. They weren't sure what was going on, so they went ahead and gave 3 baby aspirin to this patient on the way to the emergency room. Blood tests, the vitals, the chest x-rays, all kind of led to the determination that this was septic shock, as well as the left lower lobe pneumonia. So they started this patient on Pulmicort. That was because the patient was already taking that routine Symbicort BID at home every day. And so they also started Duoneb every 4 hours. The cough technique and deep breathing protocols were implemented for this patient. And there was a bilateral pleural effusions with this patient. The thing was, the left pleural effusion was worse, and so there was a chest tube inserted kind of mid-axillary, lower part, to help drain that pleural effusion for that patient. So then we go on and we look at this patient's history. This patient has a respiratory history. They're known to have congestive heart failure. This patient has COPD, and this patient has had pneumonia before. This particular person is a current smoker with no intentions of quitting and had smoked for most of their adult life, although no actual pack years were available to me. But that tells me that this patient had probably been smoking for close to 60 years if I was to deduce. This patient was retired, and their medical history included septic shock, which was part of their current diagnosis. They had chronic kidney disease. They had the left lower lobe pneumonia with this current diagnosis, as well as coronary artery disease. They had issues with anticoagulation. This patient had COPD, and they had also had a pacemaker put in several years before. So when I first saw this patient, I saw them on the 7th day after they were admitted. So while I wasn't able to see all of the initial findings, I found this patient to be very interesting because we were covering shocks, but also because there was a lot of discrepancies between what we had learned and what I had seen. And so that was why I chose this patient. Skin color was normal, pink, warm to the touch. This patient was not having any altered level of consciousness. They were very alert, very pleasant, oriented ×3. They were not using accessory muscles to breathe when I saw them, although I would assume that upon initial admission they were. There was no edema that I noted. The chest expansion appeared to be equal. The vitals were heart rate at 72, that's normal. Respiratory rate was at 22, but it really bounced around. The SpO2 was at 97 on 3 liters. This patient was on the nasal cannula. That SpO2 kind of fluctuated as well. And 3 was the baseline for that patient. The temperature was 36.1 when I saw them, pretty close to normal, although the patient did have a fever upon admit. And the first time I auscultated, I noted clear and diminished breath sounds, but I was told in report that upon admission and for days prior, coarse and diminished sounds were noted as well. So I started looking at some of the risks and comorbidity of this patient. What kind of things would have led them to get this type of condition. So the first thing I noted was that this patient's age played a role. Older patients don't necessarily get as much activity, especially this patient where they had COPD. They weren't getting up, they weren't getting moving. This patient was a current smoker, had no desire to quit smoking once they got back home. So all of those things led me to say, yep, this patient was at risk for the pneumonia. And any pneumonia that isn't treated, we know, is an infection, and if it's not treated appropriately, if it's not treated quickly enough, it can turn into sepsis, and that can turn into shock. So those are the types of things that kind of told me, yep, this patient was at risk. So some of the blood values that they drew upon admission, the white blood cell count was at 19.4. It was a little high because 4 to 11 is pretty normal. So this was a high white blood cell count, and that can be attributed to the infection. Red blood cell count was 4.04. That's a little low, and the hemoglobin was pretty normal. But I would attribute that red blood cell count being low. When the systemic response occurs, it can help kind of destroy the red blood cells with all the inflammation and things like that occur. So that could be attributed. And then we'll also look forward, and we'll see that this patient's INR level was extremely high. And as we heard before, this patient also had anticoagulation issues. So this patient could have been losing some blood, maybe a little anemic because of that condition as well. Some of the lab values that I looked at were the hematocrit, the sodium, and the potassium. The hematocrit was a little low. Same thing, could be attributed to that bleeding and the systemic response. The sodium levels were normal, and the potassium levels were also in that normal range, which I was surprised because I did expect some of those serum electrolytes to be altered, so I was surprised that those were in the normal range. Some other lab values I looked at were chloride. Chloride levels were normal. However, the BUN, and that's the blood urea nitrogen level, as well as creatinine level, were a little bit high. As we saw in the initial patient information, this patient did have some kidney disease, and so that could be part of that, as well as this, where we have infection and these vital organs are not getting all of the oxygen that they need, they kind of start to shut down. So I'm sure that that also plays a role in those labs being high. Albumin, we had glucose level. The albumin level was down, but not by a lot. I would say the infection probably caused that. Glucose levels were a little high. That can be seen really anytime a patient has inflammation, as well as anytime a patient has steroids. The glucose levels can be a little high, but I didn't find that to be an alarming number by any means. platelet levels were normal. So here's where we're looking at this INR. So normal INR is 1.1 or lower. So this INR was 10 times higher than it should have been, more than 10 times. When this number was found, the doctor was immediately notified. This patient's INR was telling us that their blood is dangerously thin. Like, this is a serious problem. And so, as I was talking about before, that can lead to maybe some of those lower red blood cells, hemoglobin levels. This patient could have had some bleeding with this really thin blood. So I thought that was interesting to note. And I did not put this in here, I guess, but the thing that I found also really interesting was that this patient's lactate level that was drawn upon admission was only 1. So, we learned that anything above 2 indicates sepsis. So I started asking questions because I thought that was kind of a telltale thing. You had to have this high lactate level in order for it to be considered septic shock, and that's not the case. There's several contributing factors that can lead to that diagnosis. So the fever and the low blood pressure that was seen, I think the blood pressure was like 90/80 something. It was low, and the patient being warm to the touch and having these different high white blood cell count, all of these different things contributed to that diagnosis. So although the lactate level was not abnormal, other things contribute to that diagnosis. So I found that to be really interesting. I also found it really interesting that no ABGs were drawn. When I asked about that, they said that they felt that the lactate levels were enough, and no ABGs were drawn throughout the entire course of this patient's stay. So this patient was here at least 10 days, and there was not an ABG drawn, just the lactate level, which I also found very interesting. This is my patient's chest x-ray, and in this chest x-ray you can see that there is kind of that fluid level line at the bottom showing the bilateral pleural effusions. You can see that on the left side the pleural effusions are a little bit more they're a little bit more serious, and so that is why the drainage tube was placed on that left lower mid-axillary line to help drain that pleural effusion. You can see some of that fibrosis and consolidation from the pneumonia as well. If you look on the left side, you're also going to see the pacemaker and some of those lines. So I thought it was very interesting that we could kind of look at this chest x-ray and try to determine what was going on. Some of that fibrosis is probably going to be due to the fact that this patient has been a smoker for so long and that they have the COPD. But I found this to be interesting. So that is the chest x-ray from the patient. So the doctor that read the chest x-ray felt that the findings were consistent with left lower lobe pneumonia, parenchymal disease. The blunting of the postphrenic angles showed the pleural effusions and the patchopacities, especially throughout the left lower lobe, indicated that pneumonia. So as I said previously, the drainage tube was placed, and they could see that the consolidation had improved. So that was good. The medications that this patient was on, non-respiratory medications, amiodarone, that was for heart rhythm issues. The Lipitor was for high cholesterol. Lasix was being given as a diuretic. The sodium chloride was fluid replacement, and Zosyn was for the treatment of the pneumonia. The respiratory medications that were given to this patient, so we had the Pulmicort that was given via nebulizer instead of the Symbicort that the patient did at home. So that was in the dose of 0.5 milligrams. Pulmicort is indicated for the reduction of swelling in the airways, and that's taken twice daily. methadone, 0.5 and 2.5 milligrams, also nebulized solution. Of course, if we're giving both of these medications, the duodenum is given first, and that is indicated to open up those airways. So those were the 2 respiratory medications that were given to this patient. So my suggestions were to send the patient home with a coronet or some type of bronchial hygiene therapy, coronet, acapella, etc. The patient was having some amount of luck clearing secretions with the deep breathing and cough. They were very open to that stance. I just felt like because of the patient's age, maybe some type of bronchial hygiene therapy would have been beneficial to this patient. I also think that the patient should be sent home with the duodenum treatments, at least for a while, once that patient is dismissed from the hospital, just to help keep those airways open. I worry that with this patient's desire to continue smoking, I worry that the pneumonia may not resolve like it should. So I would just hope that the doctor encourages this patient to really try to cease the smoking, as well as get them up and moving. Maybe have a little bit of an exercise routine, just to help clear that up and keep it away after it's resolved. Those are all suggestions that I have that I think would be really beneficial to this patient, and also maybe a little bit of pulmonary rehab. I think there's just so many resources that people don't know about that can really help them to live a more fruitful life. And so pulmonary rehab might also be a really nice option for this patient. So here were some of my expected and the actual observed assessments. So, we expect to see tachypnea. It was seen occasionally with this patient. Their respiratory rate really bounced around. Sometimes it was as low as 14. One time I saw it as high as 26. So we just kind of monitored that. We would expect a fever. The patient was admitted with a fever, but the fever was brought down by the time I saw them. Tachycardia would be noticed, but I did not see it at all. Anytime I assessed my patient, tachycardia was not something that I saw. Hypertension would be something that we would expect to see with pneumonia patients, but it was actually hypotension that we saw, and that was due to that septic shock. And as I said previously, that was one of the diagnosing factors. Pleural effusions were noted bilaterally. The increased density was seen as consolidation, especially in that left lower lobe. The lactate level was not higher than 2, like we said, but there were those other contributing factors. The patient was initially brought in with some dyspnea, but that was cleared up by the time I saw them, and we would expect to see a decreased level of consciousness, but I never noted that at all with this patient. So some of the expected outcomes, I would expect that the patient be discharged within the next few days, hopefully with duo-neb and bronchial hygiene therapy. There should be a follow-up appointment to track the status of the patient's recovery, make sure they're doing those things they need to do to make it healthy as possible at home. 2 months post-discharge, hopefully this patient's going to be back to living a normal life. But this patient spent a lot of time in the ICU, and they might need a little physical therapy to rebuild that strength that they lost being in bed for so long. 1 year post-discharge, if this patient truly decides that they don't want to quit smoking, and it seems unlikely that they will, I would expect they're probably going to return to the hospital for another issue with reoccurring pneumonia or some kind of an exacerbation of the COPD. I hope that this patient complies with the physician's orders, but as we all have probably seen, older patients kind of have their own thoughts about how they want to live the rest of their life, which is their decision. And so we just care for them when we have to see them again. These are the resources that I used. I used some information off the CDC website. I used my Desjardins book. I used my Wilkins book, my Egan's book. I also did some research on the Mayo Clinic website, and I had a specific preceptor that was very knowledgeable and gave me a lot of information that I utilized in this case study. Alright, and that's all I had. Thank you for watching.